So with that, we're going to dive into our first panel on understanding the complexity of infodemics and public health emergencies. And that's going to be moderated by our colleague, Dr. Seema Yasmin. So Dr. Yasmin, thank you and welcome.
Thank you so much. Hi, everybody. Thank you so much for joining us today. And welcome to this foundational panel in which we'll be examining the complexity of infodemics during public health emergencies. I'm Dr. Seema Yasmin. I'm director of the Stanford Health Communication Initiative and a clinical assistant professor of medicine at Stanford and a visiting assistant professor of crisis communications at UCLA's Anderson School of Management. And I'm really happy that we're going to be joined not just by very esteemed individuals for the next panel, but really, I think, the perfect people to guide us through this discussion. So much of what we'll be talking about over the next 2 days is appropriately very practical and very much about the future. It's very forward-looking. But I think it's really pertinent to begin with these individuals to really ground us in the historical context of infodemics and to also help us dig deeper into the present situation. We're going to begin with some history lessons on infodemics, looking, as I mentioned, at those past health emergencies that have really played a role in getting us to where we are now. Then we're going to learn about the state of infodemics today and why they are an ever-growing challenge, even though they've been around forever. We'll learn about the impacts of infodemics and how people experience them. And finally, we'll learn how public health officials are addressing today's infodemics. I can't get into the brilliant bios of all of our panelists because there's just so much to say about each of them. So I do encourage you to look up the speaker biographies. I will just be introducing them by name and their institutional affiliation. Each panelist will talk on their area of expertise for about 10 minutes. And so I'm really happy to say that we'll have a robust time for Q&A, about 50 minutes. I have a ton of questions for them. I study new paradigms for public health crisis communications, and I also study the nature of America's ever-growing informational and news deserts and the impacts that those have on our public health. I encourage you to jot down your questions while you're listening, to pop your questions into that Q&A that you see at the bottom so we can have a really good conversation. So without further ado, let me address our 4 panelists in the order in which they will be speaking. First up, we have Nancy Toms from Stony Brook University, who will be followed by Tina Purnat from WHO, Dietram Scheufele from the University of Wisconsin-Madison, and Umair Shah from Washington State Department of Health. So welcome to our panelists. Thank you for making time. And Nancy, we'll begin with you.
Good morning. Thank you for inviting me to participate. I'm going to start by sharing findings from a Health Evidence Network report, number 77, that I wrote with my Dutch colleague, Manon Perry, on behalf of the WHO European Division. There's a link to that report on our workshop webpage. Please download it, read it, and send me your thoughts. Until recently, historians have not played much of a role in understanding infodemics. Understandably, because of the dramatic impact of the internet and new forms of social media, we tend to think of infodemics as having, quote, a short history and a long future, as one researcher wrote in 2021. But if we look at the core elements of an infodemic, defined in WHO terms as too much information, including false or misleading information, it's clear that those challenges predate the 1990s. In our HEN report, we set out to look at the historical roots of the COVID-19 infodemic. We did first a general review of the literature on infodemics to generate questions that we then applied to 3 historical case studies: the 1918-1919 influenza pandemic, the beginning of the HIV/AIDS pandemic in the 1980s, and the 2003 SARS outbreak. Our analysis focused on changes in public expectations of scientific authority, state involvement in epidemic management, and relationships between public health experts and the media outlets they depended on to share information. We paid special attention to the early stages of each outbreak when scientific uncertainty was at its height and no drugs or vaccines were yet available. In other words, the period when generating public support for non-pharmaceutical interventions was most critical. We looked at the challenges of developing a scientific consensus about a novel pathogen based on very different types of scientific evidence and the misinformation inadvertently generated by the self-correcting practices of science. Finally, we identified shifts in both science journalism and media coverage of science issues that escalated the breakdown of older forms of filtering or curating information. In general, we found that infodemics flourished in the expectation gaps between an idealized faith in science and the hard realities of what science can produce at short notice. Comparing those gaps across time gave us a better sense of what factors widen those gaps. Information-related problems were already evident in the 1918-1919 pandemic, but they were mitigated by two factors: the lower expectations that science produced fast answers and solutions, and the relative willingness of the dominant media of that era, newspapers, to support government and public health policies during wartime. Those who opposed those policies had few means to gain public attention speedily and widely enough to make a difference. It is with the 1980s AIDS pandemic that the problems we are so familiar with today, higher expectations of fast action, demands for public accountability, and the ability of citizen groups to talk back to public health clearly emerged. Cable, talk shows, and other new forms of media upended older patterns of editorial control, both of medical and general media sources. Journalistic conventions of so-called both-sidism and a new privileging of man on the street interviews allowed a rapid, often chaotic amplification of viewpoints. By the 2003 SARS outbreak, which first inspired the use of the term infodemic, economic global interdependence and greater ease of travel made that landscape even more complex. Global economic and national security concerns complicated, timely, accurate communication regarding the outbreak's extent and severity. And those challenges were compounded by expanding access to the internet and cell phones, but traditional media also played an important role in amplifying information-related problems. Overall, our historical analysis supports key points that have emerged from contemporary analysis, that the abundance of information alone does not create information-related problems, that changes in the filtering and curating of information are critically important, and that so-called whole society or offline factors, the larger social, economic, and political context of the epidemic are critically important to understanding infodemics and managing them. I'd like to conclude with a few reflections on my reading of almost a century's worth of efforts to learn lessons from past experience. And my sense of the reasons that so many of those lessons are in fact not learned. What are the recurrent mistakes that keep the panic neglect cycle going? Just going to mention a few complex problems that we may want to discuss in our workshop. The first problem is the difficulty of addressing those whole society issues. For example, extreme income inequality, structural racism and misogyny, the distrust engendered by unresolved legacies of slavery, colonialism. In policy documents, those whole society issues are often mentioned, but they do not necessarily align well with the recommended measures. For example, in post-crisis funding schemes, The bulk of new investment tends to go more or less in order of value toward top-down disease surveillance systems, basic science research and development, and expanding acute healthcare capacity, for example, buying more ventilators. The smallest share of the preparedness pie goes to the prevention agenda, and direct funding for community-based public health initiatives is an even smaller part of that. Yet we have good evidence, including the report that Sundelson et al. Had prepared for us, that community-based networks using trusted local leaders do perhaps the most effective job of combating distrust and fear in a crisis. And that it is essential to have those local networks in place before a crisis. How do we direct more funds to building and maintaining those networks? A second complex problem has to do with the inability to separate public health science from its state sponsorship. Public health is a function of the state and thus heir to all the complications that come with that fact. Playing politics with public health has a long history, but that history or that tendency has become extremely troubling just in the past decade. A case in point, the problem of censorship and self-censorship, both formal and informal. Those problems are difficult to acknowledge, much less counteract. In their 2022 book, Infodemic, Columbia University journalism professors Joel Simon and Robert Mahoney have called attention to how epidemics have enabled censorship, direct and indirect, that in their view has, quote, made the world sicker and less free. And this is not a problem just in so-called authoritarian countries, but very much a problem in democratic nations, including the United States. A third problem is how to prevent media attention to infodemic problems from overemphasizing the negative and inadvertently reinforcing images of a hopelessly irrational, unreliable public. Now, we're all familiar with the backfire problem, that by correcting mis, dis, or malinformation, we can inadvertently disseminate it more widely. Now, recent research suggests, as Sundelson et al. Note, that this problem may not be as bad as we feared. Yet, in the context of political actors pushing a science is broken narrative, the media tendency to highlight the most outrageous forms of dis and malinformation can obscure the reality that, given time, most people can be reached through leaders they trust with messages attuned to their specific experience. I worry, as a 2020 commentator put it, that, quote, believing that the majority of people could not in good time find their way to reliable sources constitutes the real fake news about COVID-19. How do we amplify the message that with time and patience, persistent community-based efforts do work? As Sheila Jasanoff and other scholars have suggested, COVID-19 has become a critical turning point in science's role in democratic societies. Ensuring that both science and science communication are more reflective of diverse perspectives and more dedicated to solving whole society problems is essential to making sure that at this fork in the road, we take the right path. Thank you, and I look forward to working with you.
Thank you so much, Nancy, for that, for grounding us in that historical context. We'll now hear from Tina Purnat at WHO.
Hi, Seema. Hopefully you can hear me.
Yep, can hear you great. Thank you.
Great. So thank you very much for inviting me for a discussion with a distinguished panel. I'll contribute a perspective from a global and policy points of view, and I hope that this complements the discussion with other panelists, and we can discuss other aspects as well later on. So you've heard this already. As you know, the infodemic occurs during an emergency as an overload of information of varying quality, and this includes mis and disinformation. infodemics affect communities, but what I'd like to discuss is that they also affect health systems. Many of the health systems were not ready for COVID-19. For example, early in COVID-19 pandemic response, health departments in the US were still sharing data with CDC via fax. And the bottom line is that COVID-19 has highlighted major underinvestment in health systems and technologies used to exchange health information, much less analyze it, and then put it to immediate action on the ground and in health guidance. Infodemic management is a new public health practice to address a novel public health problem. And okay, so why do I say novel? If rumors and health misinformation have been a part of health service delivery and prevention efforts for as long as there have been purported cures for human disease. Let's think first of the speed and scale. The avalanche of information that accompanied COVID-19 has never before been seen at this scale. And this posed a unique challenge, not just trying to address it, but also to monitor it and to understand it. Infodemics and health misinformation have affected communities and health authorities in major outbreak responses before, and this included supposed poisonous polio vaccines in 2019 in Pakistan, where videos of children supposedly poisoned and having seizures led parents to storming local hospitals and burning down emergency rooms. Or in the 2017 measles outbreak in Hennepin County in Minnesota, which was tied to the Somali community, where misinformation about the measles vaccine sent back home to Somalia then increased vaccine hesitancy to measles campaigns there as well. Now, the nature of what is a community or who is a trusted messenger has changed as our societies have changed. And as challenging as these infodemics were, they were a mere foreshadowing of what we experienced during COVID-19 at global and local scales simultaneously. Now, the challenge to the health system and how to manage questions, concerns, information voids, and circulating narratives has been growing in scale and speed over the past 15 years. And we have not prepared the health systems to manage or to respond to it. Health departments have not been able to keep up with the pace of the increasingly digitized society. Now, what does that mean? Well, we live in a society where individuals are more likely to report outbreaks of fire on Twitter before the local fire department does that in places like California. Now, these problems are not unique to health departments in the US. People here in the US have access to health services and health information from reputable sources like CDC and the FDA. In other countries and contexts, there's much varied trust in health systems who might not regularly provide health information. However, what all health authorities across the world are facing is that it is not only the provision of health information that health authorities need to be worried about. This is not a challenge only to risk and crisis communication, but to health system service delivery and public health practices. We need to recognize that the online environment where information is shared shapes the experiences of online users, and this in turn can impact their knowledge, attitudes, perception, and behavior in their offline interactions and in life. Health policies and guidance yet needs to be considered to support and guide health departments in their work. Now, in public health, we seek effective intervention approaches to promote public health, but the challenge is that in this case, is also how we address structural and systemic factors that contribute to vulnerabilities to the infodemic. For example, in discussions on how to promote resilience to infodemics and health misinformation, scientists have pointed to the need to increase the digital literacy at the individual level to help people address and recognize health misinformation. But that doesn't solve the structural problems that contribute to how infodemics spread and how health misinformation ends up in people's feeds and on their phones. So we heard about the 1918 Spanish flu pandemic. at that time, information spread much more slowly and in pockets, and it affected less of the global public health response, or it affected fewer communities in other parts of the world. The challenge was not global and local all at once, and the speed of information exchange did not exceed the response of health authorities. What's novel now is that the health authorities must get much better at quickly understanding questions, concerns, and circulating narratives in communities that change rapidly during an emergency. And then at the same time, they might also need to recognize that health authorities are only one of the sources of health information in the information ecosystem. So how we interact with it, and also how we interact with the circulating narratives, matters beyond what messages are put out. Practically speaking, what does this mean? It means that we need to train infodemic managers. At WHO, we've been training infodemic managers since 2020. The expertise to do this type of work is multidisciplinary. Health informatics, epidemiology, behavioral science, health communication, digital analytics, health promotion. These are just some of the fields that touch this area of work. And at WHO, often when we've talked about this, we've often used the metaphor of the blind people touching the elephant. So in this case, if the elephant were the infodemic and every blind person represents a different discipline, then trying to understand and address the infodemic from just one perspective is insufficient for understanding the whole elephant. For example, a behavioral science perspective might focus on individual level behaviors, but that may miss out on structural and systemic issues that are inherent to digital platforms that affect behavior. And for example, another example may be an epidemiologist may find it really difficult to understand that just because something goes viral, it doesn't mean that it will definitely affect behavior or cause harm. Another thing to note is that there's a huge gap between what is reported in the literature and how infodemics are challenging health systems in accelerated ways. We sometimes in public health focus so much on population level impacts on health and well-being that we don't think about impacts on the health system itself. So just in the last couple of years, we've seen everything from violence and stigma being promoted against health workers, to patients having worse health outcomes due to delayed care seeking, to health workers struggling to intubate patients who were denying they had COVID-19, to increasing reports of poisoning from household cleaning products and antiparasitic medication. And similar examples can be found during other recent health emergencies. So what can the health department and health policymaker do in this situation? First, we have multiple courses that will become available on OpenWHO on infodemic management. We invite health workers to take them or to let us know if they're interested in the broader infodemic management training curricula that we had built upon since 2020, and a global teaching and learning network that we're convening going forward. Some of the first infodemic managers trained in the US hailed from the immunization program from the US state of Oklahoma, for example. Second, one of the common questions we get are in relation to ethics of social listening and infodemic management, because they're related to actions by health authorities. We have a global ethics panel that has been convened that is developing this guidance at the global level. I encourage you to subscribe to the WHO Infodemic Management Newsflash. I'll drop the link into the chat so you can get news on this and the outputs regarding this. And lastly, we recommend that health authorities work with academics, community service organizations, partners to advance this space, so that the research that is ongoing right now is going to be useful and applicable to the practice of public health. This is what we try to address at the global level with the WHO Public Health Research Agenda for managing infodemics. There are many, many grants and calls for funding, both in the US such as from the CDC and also globally. And we actually include this in the WHO Infodemic Management Newsflash as well. I'll stop my remarks here, but obviously in the discussion, I can discuss how this links to trust in the health system, health information, why focus on misinformation puts health systems into perpetually an impractical reactive position, and many other things. So thank you for the opportunity, and I look forward to the discussion later on.
Thank you so much, Tina. And next we'll be hearing from Dietram.
Thanks, Seema, and thanks to Nancy and Tina for almost perfectly queuing me up in terms of just three larger points that I'm hoping to make. A lot of them are certainly big plus ones to what Tina just said. I want to touch on three things really quickly. One, why was COVID, and Nancy already kind of spoke to this as well, why was COVID kind of this almost perfect storm for communicating science and combating an infodemic, and why did it produce this amalgam, this novel amalgam of science, policy, and partisan politics, and why did that do the damage that we saw? Number two, I do want to echo something that Tina said, and that is, and also goes back to Kevin's point from this morning about using AI to combat misinformation. And that is, I would argue that we're still, with all the efforts that are underway, poorly equipped or not very well prepared for an arms race over who has the better algorithms to deliver information and or uses AI to detect or combat misinformation. And number three, I do want to return to the idea of partisan politics and some of the approaches that have been promoted about just following the science and why that may not work quite as well as we thought it did. But let me start with the first point, this amalgam of science, policy, and partisan politics. And the partisan part is really important here. COVID presented us with a set of really unique challenges, some of which were external, and that meant that we were asked by policymakers as a scientific enterprise to inform policy in real time with science that was moving dangerously fast, and a number of people have written about this, including Ivan Oransky and Adam Marcus in Wired early in the pandemic. But they didn't just move fast, it moved under a degree of public scrutiny that we haven't seen in the past, where science normally does its own thing, and then when it has interesting findings, the public starts paying attention. Here, the public followed us study by study, preprint by preprint, often contradictory. And it followed us because, of course, that science produced deeply disruptive interventions. And that's during COVID, that made COVID very different from many of the other pandemics that touched American lives in important ways, but certainly not at the scale that COVID did. And then number three, of course, what also happened in this amalgam is that lines between advocacy and expertise got blurred as scientific journals started endorsing political candidates, and partisanship started, at least perceived, started to creep in, and that didn't make our day-to-day lives easier. Some of you saw the Axios data early in the pandemic about May 2020 that asked people if the official death counts that were being put out by bodies and agencies like the CDC were correct, or if they were exaggerated, or if they were maybe underestimates. And both Democrats and Republicans disagreed with those numbers, or didn't think that they were correct for opposite reasons. Of course, motivated reasoning, confirmation biases led Democrats, 2/3 of Democrats, to believe that those numbers in reality were much higher because, of course, for them, the Trump administration wasn't doing a good job. And so obviously those numbers were wrong in their minds. But for Republicans, 2 and 5, a relative majority, the opposite was the case. So they thought that obviously the administration was doing a great job, and so those numbers must have been exaggerations. But what that left us with is really a world where both parties, or members of both parties, didn't believe the information we put in front of them because it didn't fit their worldviews. And that's not a new phenomenon. That's something that we've seen again and again. Back in 2008, the Science Indicators had these interesting data, for example, that showed that Americans, only 4 in 10 or so, believed in evolution, as opposed to other countries in Asia, like Japan or China, or European countries, where those numbers were usually around 80% believing in or endorsing evolution as the best explanation for how human beings developed from earlier species. But when you look at those numbers more carefully, Americans actually, when you ask it 2 different versions, you say, according to scientists, this is the best explanations. Americans give the exact same answer that everybody else gives. So in other words, we know what we're supposed to know. We just refuse to know it. And I think that's a challenge that we haven't really teased out yet on misinformation, where it's less about the ability to spot it and more about the motivation. All of that is exacerbated by that second point, and something that Kevin and others and Tina brought up as well. This new, what I would call a new arms race over AI and algorithms. Our new information ecology, or ecologies, maybe to use plural, is based on delivery systems that are explicitly designed for commercial reasons, explicitly designed to outperform human cognition. To push the boundaries of us being able to recognize the real from the fake. And generative AI, which has gotten a lot of attention recently, is just one example, but also predictively model our behaviors. And most importantly, narrowcast, to tailor information toward our preferences. And Tina already alluded to that, so I'm not going to spend a lot of time on that. But of course, that makes interventions tricky, and regardless of the evidence base, and Nancy spoke to this earlier, do we know if corrective interventions, especially if we engage in these algorithmically curated online environments, if that actually gives more digital oxygen to misinformation? And a lot of evidence points to that. Even if the evidence base is still out, we've all seen hours of cable news coverage of Donald Trump's tweets. Even if you don't follow anything, or when he was still on Twitter, even if you didn't follow many of his lengthy Twitter statements, you saw them most likely repeated on legacy media. So long story short, corrective interventions very often end up giving oxygen and visibility to things that otherwise would not have seen the light of day, metaphorically. More importantly, though, some of those corrections can do collateral damage. And we just published a piece, our team, in Vaccine, where we looked at some of the corrective interventions, for example, around mRNA vaccines not containing a live virus. Both the World Health Organization and the CDC had correctives up, and we used their correctives in an experimental design where we looked at one outcome, meaning can you actually correct the misperception that the mRNA vaccine uses live virus, and you can, and that actually produces better outcomes, more correct outcomes in respondents. At the same time, you also produce, when you do that, much higher concerns about the societal risks of a live virus. Unintentionally, of course, but we still use live viruses in some vaccines. So we may be doing damage in some areas by correcting or quickly and without the necessary background research, intervening or correcting pieces of misinformation in one area. So those collateral effects are just one aspect, and hopefully we can dive into some others later in the discussion. So that brings me to my last point, and that is the just follow the science as a mantra that's been floated again and again and again during COVID, and actually before. It's not a new phrase. The Obama administration used it when they came into the White House, as did Biden, and many in our community, I think, have picked up on this. But I just want to highlight what that looks like to many audiences. If you look, for example, at what the AstraZeneca vaccine, how that played out in the US and in other countries, you see that there were concerns, for example, about blood clots in particular age groups and demographics, that ultimately the U.S. said is not enough of a concern, even though we said that we didn't use AstraZeneca widely in the U.S. at all. If you look at Germany, for instance, the then German Chancellor Angela Merkel actually publicly got vaccinated with AstraZeneca because she said because she wanted to show to the public that it was safe. Meanwhile, in Denmark, just a couple of weeks around the same time that Merkel was vaccinated, Denmark said, we're not going to use this at all. This is not safe to use. So you have 3 different countries coming to very different conclusions about AstraZeneca. All of them are following the science. All of them are making a good faith effort to follow the science. They just come to different policy conclusions, and that's absolutely the way it should be and has always been. So this idea that there is a certain policy outcome that science dictates in very often doing pandemics, especially fast-moving pandemics, is just not true. And we're not doing ourselves a service by pretending that it is. All of this together, and what I said earlier, this perfect amalgam or imperfect amalgam of science, policy, and partisan politics has also led us into a space where we've heard now a number of statements about declining levels of trust, and that's a complicated question. But at the high level, science has always enjoyed a great level of trust among the American public, and that's good. If you look at those data that the General Social Survey collects for the National Science Foundation for the science indicators, you see a widening gap in 2021, the last data collection, where you have record highs of approval of science or trust in science among Democrats, who, of course, see this as a signaling device against what they felt was a pushback by the previous administration against science. So for them, it becomes part of their political identity. But maybe more disturbing are slightly declining numbers. They're not the same spike as Democrats are showing. The decline is not as strong, but slightly declining numbers for Republicans and for independents. Combined, of course, those 2 groups make up 7 in 10 Americans. So 7 in 10 Americans have not seen a lot of increase in trust, or have even seen for Republicans slight decreases. The widening gap is now along partisan lines, with the 2 groups that we're leaving behind being independents and Republicans. And certainly in the US, that's a real concern, but we're seeing similar disconnects along partisan lines, certainly in Germany, where I grew up, but also in some other countries. So hopefully we can spend a little bit of time talking about that as well. But I'll kick it over back to Seema.
Thank you, Dietram. And now for a presentation from our final panelist before we open up for Q&A. So I hand it over to Umair.
Thank you, Seema. Thank you for moderating this session. I just want to try to do my best not to repeat what Nancy, Tina, or Dietram said. I do think they've made some incredibly salient points, and I do want to also recognize Howard Koh as the chair of this convening, and just want to recognize the incredible work that he has done over the years. I come at this from a number of different angles. I am the Secretary of Health for the great state of Washington currently, and came into this position right at the time, actually the week that vaccines arrived in the state of Washington. Prior to that, I was the executive director in the local health authority in Harris County, Texas, and Houston. And so I've seen from both the last 2 years plus here in what would be called from the political recognition of a blue state, and also being in Texas, which has otherwise been politically classified as a red state. And I've seen and been able to operate and be a part of the ecosystem of public health in both types of communities. And I come at this both from a state perspective and also a local perspective, but also as a healthcare provider perspective, as an emergency department physician for 20 years in the VA hospital system in Houston at Texas Medical Center. And I recognize that a lot of what we're discussing today is not just about the science of as we say in medicine, there is an art to medicine. There's also a science to public health. And there's also an art to public health. And I think one of the biggest challenges we have is recognizing how we bring both of those together. So we know that in the infodemic and the response to infodemics is a relatively new challenge, but we know that this is not, as we heard earlier from Nancy, this is not something that has just come about in the last 2 years or 3 years. This has been going on for a long, long time. What has happened is, though, this has worsened in what we have been characterizing. And I would go with what Dietram said, in that I do believe that we are not adequately prepared to respond to the infodemic. And in fact, I would say from a state and local public health perspective, I absolutely do not believe that we are adequately prepared to respond, nor do we have the capabilities, nor do we have the capacity, nor do we have a vision for what response is, and nor do we have the political will to invest in the very skills and skill sets that are necessary in order to fight not just, for example, an infectious disease pandemic, but the infodemic that certainly goes along with this. This is not new by any stretch of the imagination. I point to a few things that I have been a part of over the last several years, just to highlight. One is the Astrodome Hurricane Katrina response back in 2005 in Houston, Texas, where we had over 27,000 evacuees in the floor of the Astrodome. I think many of you will remember that. But one of the rumors that was going along in the midst of that floor was the fact that there was rampant tuberculosis throughout the floor of the Houston Astrodome, to the point where evacuees from the Gulf Coast, from New Orleans and other places, felt very much uncomfortable or unsafe from a health perspective, as well as responders were walking around with certain medications because they thought that they needed to combat tuberculosis when it did not exist. The second story is back in September of 2017, after Hurricane Harvey, we, as you know, oftentimes spray for mosquitoes post-hurricanes, because you have, especially in a community such as Houston, where you have an expanse of humidity and land and water related aspects to why mosquito breeding would occur. What went on the internet, though, it was through a Facebook page that later on was debunked by Snopes, was that the Harris County Health Department was spraying for mosquitoes with an insecticide, which was dose dependent and safe to use in the US, but that we were recommending that constituents or people wear gas masks. And that was a rumor that went through very significantly in the midst of our post-Hurricane Harvey response. Fast forward to February of 2020, Harris County had to launch a rumor control page because we had the unfortunate news where people were not frequenting, for example, and we did not have a confirmed case of COVID-19 at that time, our Asian American communities, because they were concerned about COVID-19 was rampant because of the vilification, especially of Chinese Americans and Chinese American communities. So there's a lot to unpack there. But when you fast forward then, as I came into Washington, I recognized that what happens in the I-5 corridor in Western Washington very much can be countered by what's happening across the mountains in Eastern Washington or Southwest Washington, where there are, as Dietram mentioned, there are potentially political forces that are at play. So I think we do need to recognize the difference between misinformation and disinformation. Misinformation, where there may be unknowingly, we know previous studies showing up to 38-40% of people unknowingly have forwarded information that turns out to be false. But what happens when it's not unknowingly? What happens when it is truly knowingly? When there is a reason to cause chaos, there is a reason to second guess, there is a reason to use, whether it's political, other reasons, to cause a rift in understanding of and a response to an emergency. That is a significant concern that all of us should be thinking thinking about. When you add into that the 24/7 news cycle, the multitude of channels, and the fact that this is a global phenomenon. So we're not just fighting what's happening in a Texas or what's happening in a Washington, but what's happening across the globe. We truly know that infodemics are significantly concerning when it comes to how do we respond to them. As well, I would add into this that in the midst of an emergency, we have what happens in the midst of an emergency in the middle of a patient in an emergency department or a hospital, where a patient has anxiety, has concern about their medical information, their health, what's happening, especially if you have somebody who's coming in with a myocardial infarction, a heart attack. There is a significant concern about what is this going to do for my own health. When you amplify that, not just from an individual standpoint, as Tina mentioned, but from a population health standpoint, now you're talking about adding into the midst of an emergency community anxiety and community psychology concerns that are very much about the collective trauma or the collective anxiousness of communities and populations as they are responding. In the midst of all this, you have delay or denying of truth, and a lot of that is very much what we do or what we see all the time from a healthcare provider perspective, is that when we try to provide information, sometimes it's not so pleasant information to our patients. There is a denial or there is a delay in even wanting to return a phone call for that healthcare provider's office. So when we put all this together, the concern that I have is that you have a number of different modalities that we in public health are oftentimes not able to track. We can certainly look at what's on the internet. We know there are social media channels, but we also know, especially in certain communities, and also that link of those communities with international settings, that apps such as WhatsApp or even TikTok or Facebook or Instagram, or IG, especially when it's more about the photos and the pictures that can easily or more readily be doctored, that very much these kinds of platforms become very concerning, because we can't always follow to the nth degree to be able to respond and bring good public health information in credible sources of information, and to fight misinformation with good information, or to flood with facts. It's very hard to do when you can't even be on the platform, or when individuals are sharing with their own communities, especially on platforms. And I particularly call out WhatsApp and Nextdoor type of platforms, where many times those government or official sources of information just do not penetrate. So what I worry about, and I will bring this to a close, is that public health agencies are not prepared for responding to infodemics, that there is a trust and transparency piece that is the currency of public health. But I think one of the biggest challenges that we have is that when we put on our white coats and we add our stethoscope, or we talk about science and starts with science, that it cannot end in science, that it may be necessary, but it is not sufficient, that we must have the tools and the ability to be able to combat this, because science, as Dietram just nicely mentioned, is very much can lead to different interpretations and or get to the point of different means by which we get to the process of what is that end science review or the end science conclusion. So engagement tools, the strategies, the resources, and even the solidarity of supporting each other, whether it's at the federal level, the state level, the local level, the community level, when there is information that we don't have in our background, when any of our partners turn around and say, this is a change as we're making, or this is a recommendation that we're moving forward with, when we don't have those facts on how that's happening, which is played out in this pandemic, especially early in the pandemic, when many of our state and local partners were left holding the bag when some of the federal recommendations were shifting, but we weren't finding out until it was going on social media or right before it hit the media. So the investment in the capacity building, not just for epidemiology and science and data, but those those soft skills, as we call them, for engagement and social media, and making sure that we have the information that we can do, information and the tools so we can fight this culture war that very much is translating data into telling a story, and those newer skills that oftentimes we are not even about or able to bring to the forefront, because we even have restrictions at especially the state and local levels on the engagement in those very platforms, is a real barrier. So without those investments, I really worry that we continue to repeat what we have had, which is a infectious disease or other kind of an emergency, and on top of that, very quickly, the infodemic that follows, and we not being prepared and not having the investments and the very tools that are necessary, or the skill sets that are necessary, or the types of people who are necessary to be able to combat that effectively. And that is going to be a recurring theme throughout the future emergencies that we continue to see, because that is the one certainty, is that emergencies will occur. So with that, Seema, I'll turn it back. Thank you.
Thank you all so much for your comments. We have great questions coming in from the audience. I just want to start with a question perhaps best aimed at Tina and Nancy, although with all of the questions, panelists, I'd ask you to contribute wherever you feel like you want to. But we don't have a consensus about what an infodemic is. And we are speaking today and preparing these notes for people who are public health practitioners. So perhaps, Tina, I can start with you since you're nodding and smiling lots. Is this a significant stumbling block? How do we move to a place where there is consensus so that our guidance can be actionable?
Thank you, Seema. This is actually a really excellent question, because this is what we've been experiencing over the last 3 years. We convened 6 global infodemic management conferences that intentionally brought practitioners and scientists from a variety of backgrounds, including also the CSOs, together to discuss. And there's always inevitably this time of coming together to understand a common language and different perspectives. I tried to allude to this in my opening talk. Really, our perspectives are sort of like touching the elephant from different sides. And what we've learned is that what helps to focus, especially when we're trying to translate knowledge, scientific knowledge, into practical tools, something that people at frontline can actually then take up and implement with all of the other work that they have, that they need to do, is to really look, take the public health, be grounded in the public health principles, where if we are, for example, what does it mean to put community or communities at the center of everything that we think about? Do we think about health information equity? Do we think about specifically of how do we translate, how do we adapt our service delivery in order to meet the needs of different communities? So trust, for example, is not only about transparency and communicating to a community, but also how we adapt and deliver health services and public health programs, and how consistent we are in delivering value programs that meet the community's values, for example. So if we focus on discussing what the community and individuals need, then this opens up not only communications perspective, but also health service delivery perspective, health guidance, adaptation and formulation, and also literally also thinking about not only about misinformation that the communities are experiencing and exposed to, but what questions, concerns, and needs they're mirroring to us that we need to address.
Thank you. And Nancy?
I know there are a lot of different definitions out there. I think getting too involved in coming up with one definition that everyone can accept can in fact deflect us doing the kind of work that we need to be doing at this point. And I think Tina's point about looking at public health practice, what it means to engage at the community level, it just it shows us that that word infodemic is like a Pandora's box that just opens up in so many directions. Is that, you know, trying to make it more precise, I'm not sure is all that helpful at this stage with all the other issues that we have to contend with.
That's helpful. Thank you. Do the other panelists want to contribute, or we can move on to an audience question?
I think that the key issue is not just the definition, Seema, it's also about how it plays out in practice. Mm-hmm. And, you know, as you've, in your media experiences, you see that a lot of it is the perception. And so I think one of the biggest challenges is the theoretical pieces of this, but also how it plays out in everyday response. So just wanted to add. Thanks.
Absolutely. Thank you. So we have a related question from the audience, which says, for this work to be successful, we need a massive paradigm shift in public health. How do we push for such a change with, and then I want to see what you think about this next part, with a thin evidence base of both the direct impacts of infodemics and for successful interventions? Dietram, would you like to have a go at responding to that first?
Sure, I'll jump in, and I was partly nodding and smiling because I think that's a very astute diagnosis of where we are, and that echoes to some degree the answers to the previous question in an infodemic where the public may have a really hard, or different publics may have a really hard time separating signal from noise, and where it's not just about incorrect information, but extracting meaningful, actionable information, and where a lot of the work that is being done is based on a very narrow assumption that we're unable to do that, rather than some of the motivational dynamics that are at play, some of the political dynamics, some of the larger societal actors and so on that we all heard about. But so that then raises the question, how do we build capacity, and how do we get that paradigm shift that the question is asking about? I think one of them is a matter of training, and actually training leaders in public health of tomorrow. So not just putting a Band-Aid on what's happening now, but actually building capacity long term. And I think universities are, I was about to say ill-prepared. I don't think that's a fair assessment, but they're not as well prepared as they could for doing that kind of training. And I think there's more and more of a hunger among bench scientists for that kind of training. We at Wisconsin, for instance, offer a PhD minor or a graduate certificate for folks getting an MD or even a master's in public health in science communication. So getting formal training in what the social science tells us about how people process information, what frames, for instance, or ways of presenting value-based arguments, as Tina just said in her previous answer, communities will be most responsive to. So having formalized programs like this, I think is one really interesting way of scaling that up and really building capacity. And then the second one that I'll mention, and Seema, you can speak to this as well as I can, because we were on the committee together on the misleading information report in Southeast Asia. So this was an effort to build capacity, or to think about strategies for building capacity across disciplines, to echo earlier points, interdisciplinarity. So how do we build almost a sleeper network of scientists, of policymakers, of folks interested in pushing back against infodemics, that gets us prepared for the next outbreak of a biothreat or a pandemic, and so thinking about institutional and kind of collaborations and what those networks would look like before the next pandemic, I think is another strategy toward that.
Thank you, Dietram. Yeah, it is a paradigm shift. It's asking for there to be a cultural change. I'm very glad to hear that institutionally, University of Wisconsin-Madison is offering that. I think it's been an uphill struggle at some other institutions, and it takes so much time, and that can feel very frustrating when you're a public health practitioner. I left CDC after a few years there because I felt that communication was being relegated to a soft science, at least in the way that epidemic intelligence service officers were interfacing with different publics. That's changing now, thankfully, and I think it's changing in the right direction, but this does take time. Nancy, I'd love to hear your perspective on this as a historian.
One basic issue that I think you've all encountered is that when you go even to relatively well-educated people, they have no idea what public health is as a discipline. They have no idea of its history. They have no idea of how it is distinct from medicine and preventive medicine. So long-term, the funding to public health departments has gone down, 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 down. It occasionally, and again, I'm not telling you anything you don't already know, but when you look at where the funds follow the problems, you're not seeing that deep investment at the local and the state level that gives nimbleness. And again, I don't mean to disparage the importance of creating sleeper networks of very smart people talking, across large distances. But my concern is how you get that smartness down to a community level that is extraordinarily diverse. So that, how many millions of Americans, how many different pockets of community that we're talking about there. So to repeat what others have said, the capacity, and I think especially at the local, the grassroots, think globally, act locally, not a bad mantra for public health, but that is not, I think often policymakers, that just doesn't seem sexy. It's kind of like maintenance work in general. It's just not sexy. It's much sexier to spend a lot of money on some new, more glittery little tool. My concern is how in this paradigm shift to get attention to that upward flow.
Thank you, Nancy. Umair?
Yeah, so I absolutely want to jump in on this one. This is probably my area of angst for a long time, but I will add it into the mix here. What I want to maybe start with is saying that at our Washington State Department of Health, we recently launched a transformational plan, and it's really built on our cornerstone values of equity, innovation, and engagement. And I use those three in that equity, so it centers on equity, innovation, and engagement. And all three of those are key. One of the biggest challenges that we have seen has been this long-standing, what I call, we are the offensive line, sorry for those who don't watch American football, offensive line of a football team, and everybody focuses on the quarterback. Everybody focuses on Tom Brady or Aaron Rodgers, and that is the quarterback who is going to, lead the team and win the game. And in fact, the entire system is built upon that. And yet, if the offensive line is not strong, that quarterback cannot do his or her job. And the healthcare system, or EMS, or law enforcement is, or the community society is that quarterback. We are the offensive line. And here's where the metaphor changes. In football, you actually continue, when you win a game or you win the Super Bowl, you continue to invest in the offensive line. But what happens in public health and the way our political systems work is that the moment we start to have success, so tuberculosis rates go down, we do not need tuberculosis programs as much, and DOT programs start to wither away. Or COVID is a prime example of we built so many systems, but we don't need those systems. So now they start to wither away. So we constantly find ourselves not investing in that offensive line. And so I find this, and Nancy just mentioned this about this concern about the visibility or the unknown and the uncertainty of what public health is. We do lack visibility, and I call this really the invisibility crisis. And I testified in Congress about this. We have a crisis in our field, but by the way, it has not gotten better. In fact, it's now been bastardized to the point where now we have caricatures. It's actually potentially even worse than it was previously, because now people believe that they have an understanding of public health through a very pinhole about what COVID-19 or what they saw on TV or how they saw it play out in their community, when that truly is not what public health is. So the 3 V's, and this is back to the transformational plan of how we plan and how we have talked about how to fight this invisibility crisis, is that you have to, the first V, raise visibility of truly the work that we do. When you raise visibility, the second V, that you engender value. When there is value in something, then people or entities tend to want to invest in that. And then it is about validation with pro-health policies and or pro-health resources to be able to raise that visibility, the value, and the validation, so we can fight the invisibility, which is also the caricature of where we are as a society for public health. Unless we do that, and this is where I wake up sometimes on the left side of the bed or the right side of the bed, I feel like we have a strategic opportunity to transform our systems. But when we in public health, and Nancy said this, at the state and local level, when we have to constantly fight with elected policy makers about the importance of communication, the importance of social media, the importance of being able to engage communities, because we see those as not necessary to infectious disease or chronic disease response, then that is the struggle that we have within our field, that unless we really truly take on, we are not going to be able to transform our public health systems.
Thank you for that. I'm just so grateful that you defined it as American football, because we know what real football is. Your point about the invisibility crisis is similar to an analogy I use about a village, hypothetically defunding its fire department because the village has had no fires, absent the education and understanding that there have been no fires because there was a robust, well-funded fire department that was doing prevention work and education work. To that point, there was a small part embedded in that audience question that I mentioned that said that the evidence base for the impact of infodemics was thin. I'd like to know whether panelists agree with that or not. Is that, again, just part of what we've heard as the invisibility crisis? And whether you agree or not that the impact of the infodemic is based on thin evidence, if that is the public perception, that perhaps, infodemics don't make a big impact, or at least we can't prove it, then isn't that a problem in and of itself? Dietram.
I can jump in on that really quickly. I think there's there are layers to disentangle here, but I think the evidence base, social scientifically, is thin, both perceived and real. And I'll start with a perception. When Francis Collins left NIH, he gave a couple of interviews, including one in Nature, where he said, "Well, I wish we'd had social science, more and better social science, to guide us through some of this," which was a somewhat frustrating statement, given that there's plenty of social science that tells us a lot about how people respond to information, to misinformation, how correctives can sometimes work, and so on. So that's maybe the perception is, I think, less of a concern on the part of different public stakeholders who may underestimate the problem than I'm much more concerned if I see that from policy audiences, especially from within organizations. And this is probably not the best crowd to say this in, but I mean, NIH has a social science unit, right? So that it's of all places, that should not be where that misperception comes from. But then number two, I think, where's the evidence base? And I think the evidence base is a lot less certain than some people make it out to be. And there was great work done, funded by the National Science Foundation during the pandemic, the Societal Experts Action Network at the Academies, that issued real-time reports of where the state of the social science was, for example, on, what is the direct link between being informed or no longer being misinformed and wearing masks or physically distancing and so on and so forth. And a lot of those things we see as covariation, as correlates, but the causality is much less clear. So do I, for example, and this is what I try to set up in my intro talk, very often we don't endorse certain information because it contradicts our values or things that we hold sacred. We know we're supposed to know this. We know experts are telling us we're supposed to know this. We reject it because it contradicts our values. And this goes to Tina's point from earlier. That also means for certain communities, and I use that term very broadly, that delivery of corrective or correct information really needs to be aligned carefully to those values, because otherwise it's going to be rejected outright. So I think short answer, tons of work yet to be done on really kind of doing some of that scaling up that the previous question asked about as well. But also tons of education of folks within policy about what we do know and what we don't know.
One of the things that I teach about in my crisis management and crisis communication class is the panic neglect cycle. Nancy, you touched on this, and I wonder if perhaps you feel like there might be a perception that the impact of infodemics is insignificant because of the panic neglect cycle. Are the two connected?
I'm just trying to wrap my head around the thinness of the evidence for the impact of infodemics. Because again, it seems to me that about some issues, we do have fairly robust evidence, and that is the importance of using trusted local leaders to push messages out. That if it just comes from an expert, people are less likely to trust and act on it than if it's brought to them by someone they're already familiar with. So I'm still kind of struggling with seeing that as thin. To me, a lot of the difficulty here is in the definition of science and what science does. I mean, in the science communication field, there's been an effort to make it scientific, to have it the same kind of robust methods and evidence base that other sciences have. But that is inherently difficult in that the kinds of data that you're dealing with in order to measure it in large amounts often gets flattened. And that one thing that I have noted in this discussion, to come back to the panic neglect, is that to me, some of the left out insights are coming from a deeper psychological understanding. So you have, yes, cognitive patterns, but you also have affective patterns of how people process information. And fear, underlying panic, is a significant emotion when affecting how information flows affect people. So, that's really hard to squish into some of the kind of models we have of how you gather scientific evidence and how you act on it. It's not physics. It's not virology. It's not biochemistry. It's much more complicated. I still think it's really valuable. So even if it is thin, we need to pay attention to it. Do we need to invest it with the kind of predictive more understanding what might be possibilities, but being able to predict if I do X, Y will happen? I don't think that's ever going to happen. But I'm a historian, so.
Well, that's why we need your expertise. Thank you, Nancy. And Tina, I know you've been grappling with this very issue. So what's your take on this?
Yeah, thank you. I'd like to bring us back to the perspective of public health practice. I'm not sure if you're aware that on average it takes 17 years to actually translate scientific knowledge into practical tools that get implemented at the front line in public health in any aspect, which means that we in general lack translational science. But when it comes to this particular issue, because our information environment within which the health authorities need to operate changes, in my opinion, on average every 5 years, and we could argue and discuss this, but we literally don't have the time on how traditionally public health translates knowledge into practical tools. So just to give you an example, it took more than 20 years between science knowing that, for example, blood sugar, glucose measurement was a predictor of heart disease or diabetes, and that it should be measured. And medical doctors would basically do this themselves, but it actually took quite a long time before actually health guidance actually caught up with this. We need to actually think not only from what the scientific consensus is, we need to actually think what is practical for a health authority to do right now. And when we were talking earlier about paradigm shift, it's not a paradigm shift in health communication, it's a paradigm shift in public health. Because if we think that the basis of maintaining, building trust with community, with every single person that is receiving service from the health system, means that we need to actually think about every interaction that the person, individual, or a community have with a health authority or a health program. And that doesn't mean just with a health program directly. It doesn't mean also only just public communication. It also means their interaction in libraries, in community spaces, in other community spaces, but not only local, geographically defined community spaces. So I would actually expand Nancy's description of trusted messengers into more wider consideration, but this is where the paradigm shift really is. So we at WHO also recognize that, yes, currently there is lack of evidence in the typical epidemiological approach of measuring what is the linkage between exposure to information that people have to the health outcome. So, for example, we've partnered with University of Sydney to basically measure a person's information diet and link that to health outcomes, etc. But that shouldn't prevent us, with the lack of hard evidence in public health, has never prevented us from actually promoting health policies to the best available evidence. And we know that the health system and the health of people actually is affected. This is what we've grappled with also in our discussions at the 5th WHO Infodemic Management Conference that specifically look at measuring burden of infodemic. There's actually a paper related to that if someone's interested. So this is the challenge for us. What is the actual paradigm shift? How do we achieve it? And if this is for the health authority to address, how can it address it? Not only through the health communication and community engagement piece, but also quality of experience of the preventive programs and health system when people actually are seeking care. I mean, just don't forget still that the most trusted source of health information, anyone across cultures in the world, still across countries, is the health worker. And that means nurses, social workers, medical doctors, everyone working in the health system is still the most trusted source, meaning all of our strategies, so to say, or trust building between the health system and communities has to be built on that. What is our interaction with people that we serve?
Thank you, Tina. We have some other audience questions. I want to start with this one, and perhaps we could hear the Washington approach to this question. The audience member asked, how can we ensure that these efforts can be sustained in the future and include specific requirements for addressing infodemics and misinformation?
Yeah, thank you. Thanks for that question. And Seema, what I would say is that we can't ensure that these are sustainable unless we change the perspective on the importance of this work. That when we are, for example, providing funding, whether it's from a federal, state, local pass-through, that we require that there are elements to not just the core work that is there, but also the additional work that we know that's behind the scenes, the core capacity that we're talking about when it comes to communications, engagement, and social media. So unless we get to this policy change that, as you know, oftentimes, at least in the US system, it's federal, state, local, that until we change the paradigm doesn't shift at that federal level, it makes it very hard then for us to fight the uphill battle to convince our federal partners that this is something that's necessary. But I think it's a bigger issue than that, which is the pie has to get larger. If we do not have a larger pie, we're going to continue to always have a robbing Peter to pay Paul. We're constantly going to be having the epidemiologist fighting against the social media staff member that we're trying to hire. You're always going to have a constant one for the other. And if you invariably hire the epidemiologist, you're going to lose out on the comms piece. If you have the comms person, you're going to have tension in the epidemiology and the science folks. And I've been one of them who said, well, why? What about our team, right? And so we have to really grow the investment in public health as a system. So I think that's the other piece. The Washington approach that we're really doing everything we can is to make the argument, to have the pitch within our agency and then beyond our agency, both with our elected officials, but also outside with the rest of our public health system within the state of Washington, is to say that communications engagement and all these other activities that really truly touch people where they live, learn, work, worship, and play, that those are absolutely central to the work that we do. And in fact, it is public. We haven't gone this far, but perhaps we should go this far. And so let me put something provocative out there for this, that it is public health malpractice. It is public health malpractice if we do not truly invest in those other systems, because ultimately, if we continue to try to achieve without convincing of the work that's necessary, the investment that's required, or the skill sets or technologies or people that are necessary to be able to get this work done and to be effective in that work, then ultimately we are not doing right by the science and the other work that we do in core public health. And so I do think there is a lot that is to unpack there, but let me just stop there.
Thank you for being provocative. I have to think about that, and I'm sure I'll be quoting it somewhere soon. Do panelists want to contribute to that point or also respond to that question? Otherwise, we do have other audience questions. And actually, there's something I jotted down while Tina was talking, but it's open for all of you to address. And I think it's connected to that last audience question, which is about sustainability. And Tina mentioned this idea that if public health departments, entities in general are always just responding to misinformation, then you're in this perpetually reactive state. What might that look like, and why is that perhaps a less efficient way in which to counter the infodemic?
Shall I maybe take a stab here first?
Sure, thank you, Tina.
So yes, I mean, just imagine also from your own personal life. Once you hear something, it's much harder to dislodge it from your memory. So psychologists talk about The fact that once people actually hear misinformation or they've been exposed to it, it's really much harder to counter it in communities or basically in the cognition of any one person. And so let's think of it a bit differently. So actually at WHO, we think of the infodemic, and this is where definitions do come in handy, but it's actually more of a continuum of starting with people having questions and concerns, actively searching health information, but they can't find it. And when their questions and concerns are not met and they cannot find health information that they're actively seeking because they have a question or concern from a credible source, then they are much more likely to then seek and actually believe sources of information that are less credible or trustworthy. So if we want to be proactive, that also means that we need to get better at making, first of all, understanding what the questions, concerns are and answering them. And sometimes these are not information related to information. They are sometimes related to practical things that people in the community need that are related to the health service. This is what I'm saying. Paradigm shift is if we understood holistically and we made an effort to continuously understand questions, concerns that the community of focus has, then we can address not only better their information and engagement needs, but also service delivery and experience, or perhaps their confusion regarding health guidance, or perhaps their some kind of experience of unintended consequence of health policy that we didn't think about before. So that's the paradigm shift, really thinking from the community perspective inwards into how we design what we provide to them and how we engage with them instead of the other way around. One other thing to mention is studies have shown that there's only about, circulating mis and disinformation online of all of the conversation only makes out about 5 to 20% of all circulating information, and everything else is made up of questions, concerns, discussion, narratives. They can be hijacked to become mis and disinformation. So again, if we want to be proactive in the health space, because health authorities, we have best mandate to be interacting related to health information. If we are proactively addressing questions, concerns, and actively finding really out-of-the-box ways of providing and making health information not just easily accessible, easily understandable, but also easily shareable, then we are actually thinking out of the box. And this is a bit of plus one also to what Umair said. I would even go even further, thinking about really, and this would then enable more sustainable delivery of health programming. But it also means, for example, having an Infodemic Insights unit that would allow a health authority at lower levels of government actually be able to do this work.
Thank you. Dietram, given our work on committees together, I'm curious what your input here would be.
Yeah, no, I agree very much with what Tina just said, and maybe add a couple layers to it. One, I think so far we're largely talking about either bodies like the WHO or public health officials speaking directly to audiences and reaching them directly or through trusted messengers, and that's really important. But I think there's a second dynamic to this that really speaks to the idea of being reactive or proactive rather than reactive. There's tons of literature, for example, in the crisis communication and the public relations literature that says that you really want to establish working relationships with journalists, communicators, central nodes, and social networks during routine times when there's no conflict, when there's no crisis. Why? Because you build trust and become a trusted messenger during those times, and then you cash in on that trust when it's really hard to distinguish signal from noise, meaning during an infodemic surrounding an acute crisis. And so this again goes to Umair's point about it being at best negligent and maybe reckless to not maintain and build that capacity. And that's a strong argument for being proactive, not just with an eye toward the next pandemic, but having long-standing strategies in place for becoming a trusted resource for journalists, for other multipliers. That then are much more likely to rely on us as they share messages, as they write articles during crises. And I think that partly also goes back to and since you evoked the at least one of the committees, Seema, that you and I were on together, that was part of the idea and continues to be part of the idea of building those networks, interdisciplinary networks of scientists, of journalists, of other folks who need to work together to proactively build a foundation of best available information for public debate and public discussion, both in crises, but maybe more importantly, before crises.
Thank you, Dietram. And you mentioned my favorite word, interdisciplinary. And as a passionate interdisciplinarian, I really like this next question that's come in from an audience member. So thank you, and please keep them coming in. The question is, what methods from other fields beyond public health are applicable to addressing infodemics? And one example they give is computational science. The audience member says they're trying to better understand the disciplines and perspectives necessary to bring to the table for partnerships for public health. So very much speaking my language as a physician and a journalist and a poet. Who would like to answer this first? And I'd actually, if you don't mind, really like to hear from each panelist, even if it's briefly, just your thoughts on this. Nancy, perhaps you're the best person to get us started thinking about interdisciplinary work.
I wanted to go back to the last question because I think one of the sustainability issues that we're grappling with is if this is a particular problem in the United States, is that we have one of the highest levels of distrust in the media of any nation in the world. And yet, this is something that's emerged very strongly from my research. In crises, public health experts have to rely on the media to get the message out because they have the most capacity. The ability of serious, in-depth journalists to do their work has plummeted. I mean, they're being fired in droves. And so we're working in a different environment in terms of having partners, science journalists that we can rely on, and the political polarization being such that if you are the science journalist for the Washington Post, that somehow you're seen as less credible than, well, I don't know that Fox News has science journalists, but you understand the point that I'm making. So in those kind of big picture factors that cause us problems with the sustainability, what's going on in the wider world of journalism today, I think is concerning. Maybe I'll stop there and let somebody else. I wasn't quite sure I understood the last question, that the person is seeing computational science as the best way forward, or
as an example of another area of expertise, another discipline with which public health needs to engage. And I don't think we have a great track record in public health of working with people outside of public health, whether it's anthropologists, historians, computational scientists, so we can do better there. But that was just one example. I can quickly repeat. The question was, what methods from other fields beyond public health are applicable to addressing infodemics? For example, computational science, trying to better understand the disciplines and perspectives necessary to bring to the table the partnerships for public health. Dietram, do you have some thoughts to share next?
Sure. I'll jump in here really quickly because I think it's a really important question and a really insightful one because, as you said, it's not just this interdisciplinarity a value in itself. But I think for this particular problem, and COVID illustrated that nicely, COVID wasn't a political science problem, it wasn't a vaccine or medical problem, it wasn't just a communication problem. It was all of the above and much more. And we struggled with this for the academies, as we thought it back in 2012 when Ralph Cicerone talked about climate change and saying, well, we're not being as scientific about communicating climate change as we're being about the climate science itself. So who do we bring together? How do we build coalitions to guide us forward? We're in a similar problem, just at a much more accelerated pace right now, and in a completely different information environment. And we ended up writing a report in 2017, a consensus study on communicating science effectively for the academies. And in that, one chapter speaks to the need for a systems approach. So there's a lot of research on the human psychology and decision-making. There's a lot of research on group levels and some of the communities dynamics within and across echo chambers, filter bubbles at the group level. And there's research to some degree on the macro level. How do these things play out in societal environments? I think Tina said this earlier, where we're not the only communicators. In fact, by the time we get to a communication situation, probably other messages have already arrived in that space, no matter how proactive we are. So that macro, meso, micro is probably a pretty good grid to think about where additional disciplines like a psychology or a decision-making researcher would come in at the micro level. At the group level, I think computational work is extremely important. We're allowing us to understand how information flows, both from within and to other communities, where it emerges, in which pockets misinformation emerges, and a lot of that is insights from computational science will be invaluable for a lot of this. And then at the macro level, I think sociologists and anthropologists and communication researchers and others who study these kind of dynamics. The tricky part is to bring them all together, so we have cross-cutting research that says, well, knowing what we know about individuals, knowing what we know about group dynamics, knowing how political and social systems play out, what are the likely effects that we're going to see, and what are the likely interventions that are going to be successful. And I think that's where we still have the biggest uphill battle, but over time, there have been 4 special issues of PNAS on communicating science effectively that have succinctly tried to slice off more and more of that problem, but we still have a long ways to go.
Thanks, Dietram. I mean, yes, it's such a broad problem, and I'm remembering when Ebola arrived in Dallas in 2014, and I was a reporter at the Dallas Morning News. And even just thinking about it from a solely journalism perspective, it wasn't just the science desk's story. It was a city hall story, and an education story, and a public transportation story, and a cop story. So it kind of went across every single beat. Tina, given you are bringing journalists to the table and bringing other stakeholders to the table, what's your response to this question?
So it comes back to, if we want to make science and knowledge useful for health authorities to be able to use it, we need more translational science. That's inherently multidisciplinary and very action-oriented. So we at Dietram always advocate for as practical tools that are evidence-based as possible, so that they can be adopted in different kinds of settings. I think more and more we get to work, and this is also on in the different convenings that we at Dietram at global level make, but also when we participate in workshops like this, we get to meet a lot of people that are multidisciplinary in their work already. So, look at me, I'm a trained economist and biomedical informatician, and have worked in health policy for 20 years. There we can definitely see a lot of multidisciplinarity and multidisciplinary colleagues that are working in this space, and we need to make sure that we open doors to them. Just to the topic of computer and information science, I would even be more provocative and say, let's think about what this practically really means. What we've seen, for example, is that health authorities in general across the world are not really that great, even making sure that their health information is digitally accessible and syndicated. It goes down to very basic things like making sure that their websites have proper metadata, that their search engine optimized, etc. So where does health information go to die? Onto the second page of Google search. And this is across the health sector problem. It's not just about, when I talk about health authority, to me, that means both like a CDC, a health department, an FDA, a professional organization that has to, a medical health association, nurses health association, etc. People that work in this space, communicating and interacting and delivering health information and health services. So we have to be much better really at practically doing this. Computer science, information science can help us there. And also this idea of setting content free. When I was speaking earlier about experience of the health service, in the end, this is user experience, it's service experience. It comes down to understanding what people need and how we actually deliver what they need better. So that also means that if it comes to communication, and we can also translate this into service delivery, that also means we need to let the content go free. The best indication that what our guidance, our health guidance has been adopted is when you hear other people speaking about it, not those that are connected to us on social media that are resharing, etc. And that means, again, out of the box thinking, how do we achieve that? Because that's the true impact. So user experience actually from the information computer science can help us a lot here.
Thank you, Tina. And for the final word, I'm going to hand it over to Umair.
Thank you so much. Thanks for moderating this panel, Seema. And I just want to thank Nancy and Tina and Dietram. Just been a wonderful perspective. We've come at it from so many different angles, and yet I think there are some incredibly strong themes and common themes that really unite all of us, which is that we have to do more, and we have to do more with less, which is the real challenge that we have, because we know those investments are not going to be flowing from the trees today, maybe tomorrow, maybe next week, or maybe a year from now or 10 years from now, but we are where we are. And so we have to be markedly more creative in our approach as to how we are going to be able to tackle this, because it's happening every single day. To answer your specific question, and then I just want to make a couple of closing comments, is that I do think there's a lot to also gain from the private sector. The private sector has an incredible knowledge of brand, both recognition, but also brand protection. And I don't think that we do enough of that in public health. Is how do we both recognize our brand, underscore that brand, and protect that brand? And I think it is an incredible amount of strategy work that is required to protect the brand that we have. And it's that public health brand. No matter sometimes it feels that if it's not happening to us or not happening in our community, that it's someone else. And we do not oftentimes call out that in a solidarity way of what's happening, or the push against our brand of public health. And I think that is a real challenge that we have. And so whether somebody goes after the CDC, or somebody goes after a state health department, or somebody goes after a local health department, somebody goes after a community-based organization, all of us should be out there saying that is wrong, and we are standing up for it. And failing to do so is also part of the problem that we have. The final thing I would just say is that, this has really been an ongoing challenge that we have in the field of public health. And unless we embrace the newer tools and have the individuals and the collective will to be able to take on the investment that's required, I do worry that we are going to continue to have piecemeal approaches to this. So if we want a systematic approach and a systematic way to take this on, we are going to need to truly convince people that the investment is worth the end goal of protecting our brand, and also making sure that the information is accurate and credible and can be trusted, especially in the midst of emergencies. Thank you.
Thank you. And thank you so much, Nancy, Tina, Dietram, and Umair, for sharing your time and your thoughts. Thank you to audience members for your questions. I think this is a great place to wrap up our conversation and to pass it on to Elizabeth Wilhelm, who will moderate our next session, which is about forecasting and social listening approaches. Thanks, everyone.